Hello and welcome. Today we're diving into the world of acoustic neuroma, also known as vestibular schwannoma. This benign tumor, while non-cancerous, can cause significant issues with hearing, balance, and even vision, impacting a person's quality of life. Let's unravel the complexities of this condition and explore its causes, symptoms, diagnosis, and treatment. The exact cause of acoustic neuroma is often unknown. However, in some cases, it's linked to a genetic condition called neurofibromatosis type 2 or NF2. In NF2, a faulty gene on chromosome 22 fails to produce a protein called myelin or schwannomin, which helps control the growth of Schwann cells. Sporadic acoustic neuromas, the most common type, aren't directly inherited and likely arise from genetic mutations occurring spontaneously after conception. Although rare, past exposure to high doses of radiation to the head might also be a risk factor. Let's break down how acoustic neuroma affects the body. This tumor arises from the Schwann cells that insulate and support the vestibulocochlear nerve. This nerve, as its name suggests, has two key components: the vestibular nerve, responsible for balance, and the cochlear nerve, responsible for hearing. As the tumor grows, it puts pressure on these nerves, disrupting their function. This pressure can then extend to other nearby structures, including the facial nerve, which controls facial muscles, and even the brainstem in larger tumors. The slow, gradual compression of these vital areas is what causes the characteristic symptoms associated with acoustic neuroma. Acoustic neuromas are relatively rare. They affect approximately 1 in 100,000 people per year. They are most frequently diagnosed in adults between the ages of 30 and 60. While sporadic cases are more common, acoustic neuromas associated with neurofibromatosis type 2 usually develop earlier in life, sometimes even in childhood or adolescence. There's no known significant difference in prevalence between men and women. The symptoms of acoustic neuroma can be subtle at first, often developing slowly over time. The most common initial symptom is gradual hearing loss, typically affecting only one ear. This hearing loss may be accompanied by tinnitus, a rinsing, or hissing sound in the ear. Balance problems, such as dizziness or unsteadiness, are also frequently reported. As the tumor grows, it may press on the facial nerve, leading to facial numbness, tingling, weakness, or even paralysis on one side of the face. In rare, advanced cases, larger tumors can compress the brainstem, causing headaches, visual disturbances, difficulty swallowing, and coordination problems. Diagnosing acoustic neuroma typically involves a combination of audiological and radiological tests. An audiogram, or hearing test, can identify hearing loss and assess the function of the cochlear nerve. If hearing loss is detected, MRI, or magnetic resonance imaging, scan with gadolinium contrast is the gold standard for visualizing the tumor. The contrast enhances the tumor, making it more visible on the scan. In some cases, an ABR, or auditory brainstem response test, may be used to assess the function of the auditory pathway in the brainstem. Acoustic neuromas are generally classified based on their size and location. Small tumors are typically those less than 1.5 centimeters in diameter. Medium tumors range from 1.5 to 2.5 centimeters, while large tumors are greater than 2.5 centimeters. Tumors are also classified based on their relationship to the internal auditory canal IAC, the bony channel through which the vestibulocochlear nerve passes. Intracanalicular tumors are confined to the IAC, while extracanalicular tumors extend beyond the IAC into the cerebellopontine angle, the space between the cerebellum and the pons in the brainstem. Treatment for acoustic neuroma depends on several factors, including the tumor size, growth rate, the patient's age, health, and the severity of symptoms. There are three main treatment options: observation, stereotactic radiosurgery, and microsurgery. Observation, or watchful waiting, is often recommended for small, slow-growing tumors in elderly or patients with other health conditions. Stereotactic radiosurgery, such as Gaumet knife or Seibert knife, uses focused radiation beams to target the tumor and stop its growth. Microsurgery involves surgically removing the tumor. This can be done through different approaches, depending on the tumor size and location. Each treatment option has its own risks and benefits, and the best choice is made in consultation with a multidisciplinary team of specialists, including an otolaryngologist, neurosurgeon, and radiation oncologist. Currently, there is no known way to prevent sporadic acoustic neuromas. Genetic counseling and testing are recommended for individuals with a family history of neurofibromatosis type 2 to assess their risk and provide guidance on managing the condition. The prognosis for acoustic neuroma is generally good. These tumors are benign and typically slow-growing. With appropriate treatment, most patients can maintain their quality of life and manage their symptoms effectively. However, hearing loss is often irreversible, and other complications, such as facial nerve damage, can occur. Ongoing research is focused on improving treatment techniques, minimizing side effects, and developing new therapies to prevent tumor growth. Researchers are exploring the role of specific genes and signaling pathways involved in tumor development, with the goal of identifying potential targets for future drug therapies. Additionally, advancements in surgical techniques and radiation therapy are continuously being made to improve outcomes and reduce the risk of complications.